Objectives, I'm just going to go through 2 case examples of CurvaFix. One's going to be a pelvic fragility fracture. I think that's going to be the kind of the workhorse of what this implant can do. I think we see a lot of pelvic fragility fractures, at least in my practice, that I really wasn't treating with surgery, and this has kind of changed the way I approach those patients. And one traumatic injury in an active patient. What I want to show is kind of the ease and safety of the CurvaFix nail. What I found is that putting this in turns out it's a little bit easier because the wire is going to kind of bounce around and go where you want it to go. And that kind of makes it a little bit easier, especially in these tough cases like the dysmorphs. And then the clinical benefits, hopefully we'll show through in this. So why CurvaFix? And Amir kind of already talked about this with a device that fits the anatomy of the pelvis. You've got curved corridors, and we're trying to put straight screws in those. Using a curved implant will fit those corridors, but the other thing that a curved implant does is when you lock it, it's nearly impossible to pull that out. I like to tell the story when I was 17. I used to think I was going to be a race car driver. And I used to practice in my neighborhood. And I was turning a corner when it was wet, and my car hit the curb, and I bent the axle. And it didn't really turn after that. It didn't move the wheels. So having that curved implant locked isn't going to back out. Like normally with straight implants, when you walk, you get that motion, and the screws start to unwind and back out. This doesn't do that. At least I haven't seen it yet. It's safe, and one of the things that I talk about is the feel you get from the guide wire when you're putting it in. I would never try this, but I like to think that you can almost put this in without x-ray because you can feel the difference between cancellous bone, cortical bone, and when you're not in bone. And it's kind of like a straw in a cup, like you can feel that sliding. When you hit the ice here in the cancellous bone, it gives a little bit of crunch and resistance. When you hit the bottom of the cup, it stops. You know you're on cortex. When you hit that, you can get an x-ray. You can say, all right, I'm on a neuroforamen, or I'm trying to come out the front of the sacrum, so you can stop. And then the biomechanics, again, being curved. I also feel like, a straight, solid piece of metal, if you give that a little bit of bend, it's going to find that weak spot and break. This has a little bit of give into it, so it's not really going to break. It's going to kind of hold with the normal motion of fractures and hopefully be within that range that allows us to heal. So I'll start with patient 1. This is my 62-year-old active water skier. He was at Lake Shelbyville, which is right near Springfield, home of the Simpsons, and fell off the top of his camper and came in with this. So he's got bilateral rami fractures and a sacral fracture in the back. So I have a couple of CT cuts showing this. And I classified this as an LC2. So I always try weight bearing on these patients, especially with the fragility fractures. If they can weight bear with their fractures, I don't do surgery. If they can't, then I like to do something about it. So he failed weight bearing with therapy, and I then discussed surgical options using CurvaFix, talking to him about, hey, this is a fairly new implant. I've used it quite a bit. It's worked very well. I also talk about the postoperative course. So these patients, I like to get them up and start them walking right away. And he was very excited about that, wanting to get back to water skiing as soon as possible. So we took him to the operating room on post-injury day 3. And I think the booth is going to have some videos of I like to save every x-ray sometime on these, and so it's like a cartoon of the process of putting this in. And I gave this guy what I like to call the full Monty. So he has the posterior screw and then right and left column screws. I made him weight bearing as tolerated immediately after the surgery. At week 2, he came in with a cane and said things were going well. I think if you compare the column screw on the right, it did move a little bit, but it's still holding. And then at week 6, he came in with a cane, wasn't complaining of any pain, and was ready to get back to work. He had a job where he's on his feet at the Caterpillar plant all day long. So within 6 weeks, this patient was back to walking and ready to go back to work when before. I don't think I would have gotten this patient better that quickly. So at 10 weeks, he's got no cane and no pain. And you can see, I think you can see he's got a lot of good callus in the front, showing that this is stable. Patient 2, this is a 72-year-old female with a ground level fall. This patient came into the emergency room with this x-ray, was told everything was fine, and sent home. This patient lives alone, is very active. She was unable to walk for 5 days, came back into the emergency room where we got a CT scan showing really non-displaced on the left sacrum, but bilateral sacral fractures, and then a small fracture in the front. So I classified this as an FFP4C for Dr. Rahman's, bilateral sacral fractures, right symphysis. On post-injury day 6, so this is a day after she came in to our hospital, so I had at that point considered her to have failed weight-bearing therapy, being home for 5 days and not being able to walk. So we took her to the operating room the next day, placed this implant. Here's a CT cut showing its placement. You can see the large curve in this, which I like to put large curves in. I've noticed in some labs that if you put this in with your hand and just kind of shake your hand, it goes in straight. I think that defeats the purpose of putting this device in. You want to get a curve in there. And actually, when I start these cases, I always start sacral screws with my lateral imaging, mark where I want my start point. But on this, I mark where I want my start point, and then I move it one way or the other. If they're a dysmorph, I move it posterior. If it's a normal sacrum, I like to move it inferior to get a curve moving towards the spine. So post-op CT looked great. The patient came in 2 weeks carrying her walker, and she said, "I'm not sure why I'm carrying this around." And I think it was one of those things where the patient came in because she thought I wanted to see her using her walker, but actually she didn't need it. But she actually went to a rehab facility. I think she spent 5 days there and then was back home living alone shortly after that. And 4 months post-op, the patient has no issues. And so here's my x-rays of her. So to recap this, one, I think CurvaFix is safe. I believe it's easier to put in, and that's the nature of the curve. You can bend and bounce around the structures that you don't want to hit. It fits very well, and I think it's going to allow us to kind of rethink pelvic fixation strategies. We have all these defined corridors, and I think what this gives us the ability to do is potentially connect some of those corridors with large curved implants. So, thank you.